It's a pleasure to be here. She doesn't have to twist my arm very hard to make the 2-hour flight from Denver back to the Bay Area. This is a little switch from another mycobacteria which you came here to hear about to the other 200 that I want you to know about. Because today in the U.S. they're 10 plus times more frequent to be grown in labs. So there are many, many more NTM patients than there are TB in the U.S. And often they will filter through the TB program. That's who may make the initial diagnosis. And you may not treat them, but finding them is very important. It's case finding. It's just case finding for non-tuberculous mycobacteria. Before we get going, though, I need some to let you know about some conflict of interest. Probably 10 years ago, there were no companies, maybe one. So we're extremely happy. I'm hoping I'll have a second slide someday. Because what this means to us is drug development. New drugs are coming, and these drugs that I'm talking about, many of these are being developed specifically for non-tuberculous mycobacteria, not for TB. Now, some of them are also for TB. And so research grants from Emended and Sparrow, and then you can see the advisory boards that I have served on. And I can tell you, as of last night, there will be another, because there's another company that wants to develop a drug for NTM. So we're very excited about this. So I'm going to start off with what are this? I keep saying NTM, but what are NTM? Give you a brief review of the epidemiology, primarily because I want to make the point that this is very important. This is a very important and emerging disease. Unlike TB, if you grow one colony and it's not due to contamination, we treat everybody pretty much the same if they have drug-susceptible disease, but it's much more difficult with NTM than it is with TB. And then I'm going to focus on the two most common that you're likely to see in any setting, and that's Mycobacterium avium complex and also abscessus. So the traditional taxonomy is that this is from the genus Mycobacterium. There are now really over 200 species and subspecies. There'll be a test a little bit later to see how many you can come up with. I don't know all these. It's over 200, and almost every month there's another one that is added to the list. So this is a rapidly growing list. Now you know MTB, you know leprosy, and the rest of these we refer to as non-tuberculous mycobacteria, or NTM. There's a lot of different species. Now, if you look at time, this is going back on your left from the 70s to the 2000s, just to show you how fast these names are coming out. And there is no end in sight. Now, this isn't because these things are mutating and coming from Mars. I mean, these are because we have now molecular-based tests. We have sequencing. And sequencing can split things and name things that maybe had a different name before. The organism itself didn't change. It's just the name has changed. But this is going to continue, this increase. And something that I'm just going to mention to you, and then I'm going to pass right by it. This is a paper that came from a group of genomics people from McMaster. And they went through and they looked at mycobacteria, all of those, this is part of the problem. They didn't look at all of the species, but most of them. And they said, let's not call it Mycobacterium anymore. We're going to change the name. So now Mycobacterium abscessus is officially called Mycobacterioides abscessus. Mycobacterium fortuitum is now officially Mycobacterium. And the only one that retains the Mycobacterium genus is MTB simiae, which is a new grouping. This is now official. This is what's accepted. We have had papers decline because we didn't use this terminology. We wrote a paper that was just published last month with a large number of laboratorians and clinicians really trying to assail this genomics approach that takes the clinical importance and scenario totally out of the picture. So there actually is a battle going on at the journals and among scientists to try to forget this and stay with Mycobacterium. I don't know how this will ultimately come out, but as a traditionalist, I'm sticking with Mycobacterium. And I'm so traditionalist, I'm going to divide them in the old way, slowly growing and rapidly growing, just based on their growth rate. The slowly growing, this is a list, partial list, of some of the NTM that have caused lung disease. The list is much longer. And also the rapidly growing. And the worst thing you can tell a patient is you have a rapidly growing mycobacteria. I mean, they just think, I'll be dead next week. But rapidly growing is just a relative term, right? It just means that on subculture you see growth in 7 days. And if it's longer than that, it's slow growing. But it's still slow growing. And you, I'm sure, recognize some of these. Now, the bolded ones are what we'll be talking about today. Mycobacterium avium, Chimera, intracellular. Those are the 3 most common species of Mycobacterium avium complex, or MAC. On the other side, M. abscessus, Belledii, and Myceliense are 3 subspecies. And we're going to get into why it's important to know the names. Now, how much is out there? Well, it's not reportable in most places. There are now 11 states that report NTM, but most of them don't do it very well. The 5-county region now in Denver is a sentinel site to make it reportable. So we're going to see in a metropolitan area how hard is that? You know, how much does it cost? Is it useful? If you look at where it is, though, based on really more estimates, in 2010 it was estimated by NIH about 86,000 patients. But in another publication, which I'll review in a moment, they noted that it was increasing at 8% per year. So if you factored in that increase, then by 4 years later, it was estimated there would be 181,000 pulmonary NTM patients in the United States. How many TB patients are there? 9? You know, not that much. This is an amazing difference now in the prevalence of this disease compared to TB. You can see the darker colors are those here that have over 3,000 cases per year. Those are mainly the populous states. So what I think is more helpful is looking at the rate. And if we look at the rate, you'll see still Florida, Arizona, California, you can see that there are still high rates there. The rates are over 50 per 100,000. What is TB rate? 3-ish. So this is just trying to put into perspective the really burden of disease that we see in the United States from non-tuberculous mycobacteria. I'm focusing on pulmonary disease, but there are also extrapulmonary patients, and those cases are increasing also. So what's the state with the highest rate? It's got to be one of the darker ones. Well, first of all, those of you who live here, you're in a high-risk state, high-prevalence state. Hawaii is the number 1. Hawaii is number 1, Florida is number 2. Something in common among those: hot and humid. So these things tend to like that. They need water, but there are exceptions to that. Now, there's an exception up here. It's not hot and humid there. California, certainly parts of it are not, but look here. Why does Arizona, one of the top 5 states? I don't know the answer to that, but it was striking in this research that there's something going on there that has made it a high-risk state. Now, these are some population-based data, which is why I'm showing them. 2 reasons. One is that. The second is that, I'll show you in a second, they have trend data. So the first one was 4 health maintenance organizations in the U.S. during this time period. The second was a U.S. Medicare database, so this is biased by the fact that these are older individuals, and multiple studies have shown the rate goes up with age, so it's going to be higher in that group. Ontario, Canada, 95% or so of their isolates go to the provincial laboratory, so they have tremendous capture across the whole province. And then Oregon, led by Kevin Winthrop, statewide, it is now reportable there, not extrapulmonary NTM, but he did a study in which he was able to look at the data statewide. So you see 2 frequencies, isolation and disease. With TB, we would just have disease, because if you grow MTB, they have disease. But that's not the case here. Isolation frequency just means how many positive cultures. So in the U.S. Healthcare Maintenance Organization is about 12 per 100,000. Ontario, 22 per 100,000. Oregon, 12 per 100,000. If you go to the next column, it's about half the isolation rate. And that's about what we've seen in most studies. About 50% of people who grow it, it's harming them. And the other 50%, they may not grow it again. And that's the hard part, is knowing when it's hurting someone, when it's time to treat. But a rate of 6 per 100,000 is double that of what we see in TB in the U.S. About 3 per 100,000. Now here's what I really like about these studies is they have trend data. And you can see in all of these population-based studies from 2 to 10% per year increase. That's dramatic. I mean, there aren't many diseases that you can come up with that are increasing at 2 to 10% per year. And this is, in some cases, over a decade. So this isn't a little blip in the curve. This is a sustained increase over time. And it's quite striking. Probably one of the most frequent questions I get is, why is this happening? You know, why is NTM going up? Now, TB is going down much slower than we want it to go down, but it is going down. Well, these are some of the things we think about. You know, exposure has increased. We have much more exposure to aerosols than we did 50 years ago. By that I mean we take showers, sometimes multiple times a day, sometimes at home, sometimes the gym. So that's aerosol. If you go to Arizona, they have misters trying to cool you down at the restaurants, and maybe that's where the NTM are coming from. We've changed our plumbing. We've lowered our hot water temperatures to prevent scalding and save energy, but that really enhances the growth. They like hot water, but when you get above about 135 degrees Fahrenheit, they don't like that. There are some countries that keep their hot water higher than we do in the U.S. And so there are people trying to see if there's an association between that and their NTM rates. Some people say it's not really increasing, it's just that we're looking for it. Well, that's definitely part of it. I mean, I think that is part of it. We have more sensitive culture methods, with liquid culture systems, and now we're often doing liquid and solid at the same time. Everybody gets a CT. I mean, no matter what. Pretty soon, you go to Macy's to buy something, they're going to do a free CT. Host factors. Well, we have an aging population. We have more lung disease. We definitely have more immunosuppressed patients. And we do have this interesting concept, which is maybe we have decreasing cross-immunity. As latent TB infection goes down, maybe that's why we're not protected anymore from these environmental organisms that are in the water that you're drinking right now, in the water that you shower in every day, and in the soil you dig in. These things are everywhere. But we've been living in these same environments, and we haven't seen this amount of disease, so something's changing. We published a systematic review looking at about 22 sites in the world that had data on the incidence of TB and NTM. And in most of those in which TB was going down, NTM was going up. In 90% of them. So there is something about when TB goes down, NTM comes up. Whether that's an immunity, we don't know. And then finally, the organism. Maybe by changing water temperatures and maybe other things that we're doing, maybe we've enhanced the virulence of these organisms in some way. And yes, they were always there, but now they're harming us because they've changed. So the good news, of course, is we don't all get this. Otherwise, we'd be in big trouble if just drinking your tap water or taking a shower would give it to you. So that most people have a condition. They have a susceptibility. Here, there are 3 circles here. Underlying conditions that we know are associated with higher risk, significant exposures that we know are associated with risk, and a very interesting group that I'll talk about in a moment. But cystic fibrosis patients have maybe up to 1,000 times higher risk of non-CF patients. Alpha-1 antitrypsin, higher risk, COPD patients. Of all on that list, though, bronchiectasis, which is damage to the airways, dilatation of the airways, can be caused by many different things. That is by far the highest risk for getting NTM. If you look at the other side, there's a smaller group of people who we can't find anything wrong with them. They're often young, but they have a very big exposure. Maybe they're the lifeguard in that indoor pool that is contaminated, so they're breathing, 8 hours a day. Contaminated water. Maybe I have probably 4 or 5 professional landscapers that have MAC. I don't know if that's them out digging in the dirt all day and at the job site. I don't know, but it's interesting. But the group that probably catches our attention is the group at the bottom. This is a group, it's called Lady Windermere's syndrome. It's based on the play by Oscar Wilde, Lady Windermere's Fan. And the idea is that there are a group of women who typically are Caucasian, tall, thin, postmenopausal. And in every way you measure their body type, they're different. A study from the NIH, for example, showed that they're taller, thinner, and lighter than controls who do not have NTM. And it's quite striking. In every way you would measure kind of thinness, lightness, they're different. And they have a higher rate. Now, we don't know why this is, and people are really looking very hard. Ed Chan, who published this article at National Jewish, he's been working on this for years, trying to understand, is it a hormonal issue? What is it that makes these individuals at such high risk? But ultimately, you can have all the risk in the world, but if you don't have the exposure, you can't get it. So you got to have both. Two to tango. You got to have a susceptibility and an exposure. And so we think in this group, this susceptible group, probably they don't need a very high exposure. In this other group, we think they're not susceptible, they need a high exposure. So these have to come together in the right way to cause disease. So just because you grow an NTM doesn't mean it's harming you. So ATS and IDSA have developed what are really diagnostic criteria, but they're really guidelines to help clinicians figure out who is getting harmed and who is not. It starts with, they come in with symptoms. These are the top two. Cough and fatigue. Weight loss is a little further down the line, but it is also a common symptom. They should have a radiograph that's abnormal. There's two kind of flavors to this. The bottom looks like TB, upper lobe fibrocavitary, and that's what it's called, fibrocavitary NTM disease. Or this lady Windermere type called nodular bronchiectatic disease. The little, what looks like grapes, that's bronchiectasis. Tends to be on either side of the heart, right middle lobe and lingulus, fairly distinctive. They often have other things in their body like kyphoscoliosis, mitral valve prolapse. So there's some collagen vascular link here in them, and that's an area of research. But ultimately, it's an infectious disease. You need to have a culture. And so the bacteriologic criteria that we most rely on is they have to have 2 or more positive cultures with the same species. Many of these patients are infected by multiple species. To make the disease criteria, it's the same. And if they can't get sputum, if they're not a producer, you can do a bronchoscopy. And you'll see in the guidelines, we say 1 positive culture meets criteria, but this is something that's misinterpreted by pulmonologists. They think it means it's the same or better. It is not better. I would much rather see multiple positive sputum cultures in a single bronchoscopy because it tells me the bacterial load is higher than a single bronchoscopy. I haven't started someone on treatment for NTM for a single lavage positive culture in probably 10 or 15 years. I will then start looking now with induced sputum to see if I really think that they have a high bacterial load. So I wish I could tell you that the predictive value of meeting these criteria was 100%, right? We would feel really good about that. Oh, they meet these criteria, we should start them on therapy. It's not the case. There are 3 studies, one of which I was involved in. So this one, 488 patients with MAC, pulmonary disease, who met those criteria. All right, so we would say diseased, who didn't get treated. 62% progress, but almost a quarter were stable. And this was at a median of about 5 years. So that's tough. And then of that group that was stable, half of them converted their sputum to negative without antimicrobial therapy. So this is the problem. We know not everyone is going to be harmed just because they grow it. It makes it harder. The next one, similar size study, really similar number treated, higher number not treated, but look, about half of them self-converted. Now, things may have been done in this process. They may have been started on a vest or some kind of airway clearance that helped them, but they weren't started on antimicrobial therapy. And then Sung-Mi Moon from Samsung, who I work with, 1,000 patients, 55% treated, 45% no treatment, 35%. But the same general idea, that if you follow some people, they won't progress. So the key here is how do we figure out who those people are? We need biomarkers. We need something to help us in the clinic figure out who is going to progress, because that's who we'll treat. And if I knew you weren't going to progress or unlikely to progress. So these same studies have tried to dig apart some of the factors that were associated with progression. So we're starting to get a little bit of an idea. In terms of host demographic factors, studies have shown male gender, older age, more likely to progress. If they have other comorbidities, like lung disease. And very important and very common among our Lady Windermere patients is low body mass index. They're very thin. And so we really push nutrition as part of that intervention. Laboratory, so if they have high CRP, high SED rate, if they have anemia, low albumin, this means they're sick, and they tend to progress. Radiographically, very important, because you can see this immediately. Do they have cavities or not? If there's cavities on the X-ray, they have already progressed. That is someone you want to treat, and if they have extensive disease. And finally, what we know the least about probably are the microbial factors. But the bacterial load, if they're smear positive or high bacterial load, they're more likely to progress. And as I'll show you in a moment, the species. Of those 200, you need to know which one it is. Some you wouldn't think about treating, and some you're going to treat right off the bat. So then that ties into laboratory. Just like with TB, the laboratory is a critical component of managing these patients. And it's the same general process. You first have to think about it, and that's still something we're working on. From collection of the specimen to culture to identification, susceptibility, 8 to 12 weeks. It's the same lab that you use for TB. What we don't have is a gene expert. We don't have that for NTM. What we do have, though, now in many labs, we're starting to see other methods that are allowing us to be very precise in telling you which species it is, even which subspecies. So in National Jewish, we use both sequencing and a line probe and multitoph. We use all of these methods, and we can tell you exactly which one is infecting the patient. Susceptibility testing, it's very difficult to do susceptibility testing with these organisms. So they're not nearly as useful as that they are with TB. The ones that we would all agree you need susceptibility testing on, if a patient has MAC, you want to know macrolide susceptibility and amikacin. If they have MAB, which is abscessus, Mycobacterium abscessus, we use a fairly long panel of drugs. But the correlation is just really not very clear how much those MICs correlate with activity. The other thing, and we'll talk about, is inducible resistance. The laboratory must tell you if the strain has inducible resistance. And we'll go into more of that import in a minute. So now you've seen the patient, you've got your data, they may meet ATS criteria, but you're still trying to decide, do I treat them or not? So it's really back in the clinician's office or lab, really, because you've got to look at their clinical setting. Do they have an increased susceptibility? If they have cystic fibrosis and they're growing this, I'm probably more likely to treat than if they're totally healthy and I can't find a susceptibility. Certainly if they're symptomatic, the joke in our field is if you're not symptomatic, I can make you symptomatic with giving you 3 antimicrobial drugs. So we have to think about, am I going to actually make the person better in some way? And then the extent. This is, I think, probably the most useful. If you see cavitary disease or very extensive nodular disease, we're going to treat. Well, one area that we haven't addressed very much is the actual bug, and this is probably hard to see in the back. This is just our idea of a pathogenicity scale. So if you're sitting right here and you grow Chelonia, Simiae, Flay, Gordoni, those don't cause lung disease. So we ignore them. Not in a transplant patient, but in a typical patient. But if we go to the other side, we see Mycobacterium sulgae. That's a pretty pathogenic one. And in the middle are the ones we'll be talking about today. MAC and abscessus tend to be more in the middle, so that makes it harder to decide. But the idea here is that there is quite a difference in whether a certain species will cause lung disease. You can't possibly know all 200 species of which one, right? That's not possible. So we have to figure out how to help all of us remember this. Okay. And then the final thing is, what's the cure when you start treating someone? What's the goal? Cure, of course, is the goal if you treat someone with TB. Depending on these species, I can't cure these patients. Some are not, I'm not going to cure them. Some I will. Mycobacterium kansasii is like TB. I'm going to cure 95% of patients. Mycobacterium abscessus, subspecies abscessus, it's more like 25%. So when we're talking to patients in the clinic, we're not always using the cure word. Sometimes we can't. It depends on the species, depends on extent of disease, maybe comorbidities. So maybe what we're going to be talking about is bacteriologic conversion. Let's get your bacterial load down, see if that improves your symptoms, see if we can slow progression of disease. That may be the goal depending on the patient. So let's start with MAC. This is a 65-year-old Caucasian woman treated for Mycobacterium avium complex. She'd been treated 2 previous times with a standard regimen, which includes a macrolide, rifampin, and ethambutol. And you can see their cavity there, but also you can see how large a cavity she has. She also has areas of bronchiectasis on the right middle lobe and lingula. She's coming back now with her 3rd episode. So this time she's smear positive, and she grew Mycobacterium intracellulare. So that is MAC. It's just one of the species, but at this time the lab didn't tell the clinician which species it was, but we did. So this is a tough case. 3rd time to be treated, cavitary disease. So the most important question for us at this point is, have they acquired resistance? If they've acquired macrolide resistance, it changes everything, and I'll show you that in a minute. So we're going to come back to this person. But right now, she's got uphill battle for cure. Okay, so MAC. What is MAC? Everybody calls it MAI. Is that what everybody still use that term? Don't use that term. MAI was the term when we had 2 species, avium and intracellulare. We have 12 species that are now called MAC. So I circled the 3 most common, Chimera, intracellulare, avium. So the laboratory should be telling you which one it is, not calling it MAC. And I'll show you why that's important in a moment. So I mentioned earlier that we can identify these now through using sequencing, and that allows us to put a name. This was a study from Korea, 91 patients that had just standard phenotypic identification, and they identified it as intracellulare. They then added multi-locus sequencing, and you can see they were right most of the time, but there were some others that were misidentified and called intracellulare. Why is this important? Because there seem to be some difference in their pathogenicity. If you look at intracellulare, 72% of the time they met ATS criteria, but only 38% if it was Chimera. They're all called MAC. Most laboratories in the US only tell you it's MAC. They don't tell you which of the 12 species. And probably by the end of this lecture, there'll be 13 species, because they're being discovered very quickly. But here's how we treat it. So the first question that you will be asking in your lab is this a macrolide susceptible isolate? If the answer to that is yes, and it should be if they've never been treated, so in this patient that I showed you, this is what we're waiting on, because she had been treated. Then the next question is, they have cavities or not? If they do have cavities, we give them a 3-drug macrolide regimen, and we give it every day, daily. If they don't have cavities, we will probably treat them 3 times a week. Same drugs, slightly different doses, but 3 times a week. Just like in TB, we also have intermittent regimens. Now, if they're unlucky, probably because they were treated before, and they have macrolide-resistant disease, now the macrolide does not work. So we stop the macrolide, and then we have a very short list to choose from to substitute. So when we get macrolide resistance because somebody was treated inappropriately with monotherapy, we don't have a lot of options. Clofazimine, moxifloxacin, bedaquiline, inhaled amikacin, and a few other drugs we might pull out of our sleeve, but we don't have a lot of options. And in macrolide resistance and cavitary, we usually add about 2 months of IV amikacin. So this is kind of sounding like MDR-TB, the way we have to address this. There was a recent systematic review that looked at 42 studies, 2,700 patients. They looked at treatment success as sputum culture conversion. And what did they find? If you used a macrolide-containing regimen, it was about 52%. So that's pretty low. Again, we're getting into old MDR days when we couldn't convert people. If you use the recommended regimen, it went up to 61, and if you gave that regimen for over a year, about 66% treatment success. So we need those companies on my disclosure slide to help us. We need better drugs and regimens. But still, the majority of people we can cure. If they have macrolide resistance, totally different. If you look at people who have macrolide resistance and you don't do surgical resection, if you don't give them a prolonged course of an aminoglycoside, culture conversion is 5%. That is worse than the worst XDR. So when someone develops macrolide resistance, it's a big problem. If you do resect some and give some aminoglycoside, this is a study we did in Korea, we got it up to 15%. So we were selecting, highly selective who would get surgery. In another study from David Griffith and Tyler, by doing surgical resection and giving 6 or more months of IV aminoglycoside, so you know there was hearing loss, you know there was toxicity with that, they were able to get it back up to 80%. So this is a nightmare scenario for us. This is when someone has macrolide resistant MAC. Okay, now I've cured my 60 to 80%, somewhere in that range. What happens to them? 3 studies. One, again, from Samsung, a group I work with there, Dr. Ko. You can see the size of the studies. So microbiologic recurrence. What I'm saying here is these are people who we thought we had cured. Culture converted, negative for 12 months, and we thought we're done. They recur. So recurrence in the Texas study, about half the patients recurred. And a quarter or so in the other studies. And then using various ways to, or basically fingerprinting the organism, it turns out when they came back, it wasn't the same organism all the time. 75% of the time it was thought to be reinfection. Very different scenario than what we see in TB. And then maybe 50 to 75 in the others. So recurrence is high even after cure, and reinfection very high. Why is that? Why is reinfection so high? I didn't get rid of their susceptibility, and they go back to the same environment that they got it in the first time. So it's not really that surprising that reinfection is high. So we need to figure out from a public health perspective how to prevent infection, and that is something we know very little about. Now, why do you need to know the species? This is just to demonstrate in one of my patients why this is important. This was a 62-year-old woman from the East Coast who had fatigue and chronic cough, had actually fairly mild basilar looking bronchiectasis, but had multiple positive cultures. The first 2 were at an outside lab called MAC. When we saw her, we speciated, and it was avium. Put her on therapy, and she did what I expected. She converted to negative quickly. Oops, but then she came back with avium. I went, oh, well, let's just keep going, this happens. And then she came back with chimera. That's a different species. And then she had a chimera Youngenense hybrid. And then she was negative, and then she had a Youngenense hybrid. So this is what we're seeing. If you think it's MAC and it's the same organism, it is not always the same organism. They're getting reinfected even while you're on treatment. Now, one of the things interesting about her, because I had to go ask her, tell me how you spend your day. She spends about 8 hours a day in her garden. And so we asked her not to do that anymore. And now we're going to see, does this stop? Because she was being exposed somewhere. So what do you do in those patients who don't respond? Well, we showed in Korea that you can just take someone on intermittent therapy and just switch them to daily therapy, and about 30% will convert their cultures just by doing that. We can go to some repurposed drugs. We use a lot of clofazimine. We have 300 patients at any one time at National Jewish on clofazimine. And about 30% will convert their cultures to negative. You can use new drugs like bedaquiline. Dilamidid, not so much. We now know it doesn't really have much activity. We published that a few months ago. But dilamidid does have activity for MAC. So we do use, we have about 50 patients probably on bedaquiline. And there's some magic number, about 30% of people convert almost no matter what you do. But you have to do something. If you don't do something, then they just stay positive. But we now have actually the first FDA-approved drug for the treatment of pulmonary MAC in the world. Nothing that I've talked about so far is FDA-approved until now. So this is inhaled liposomal amikacin, approved in September of last year for treatment of refractory disease based on a phase 2 and a phase 3 study. This is the phase 3 design. So it was a randomized 2-to-1 design. And the patients had GBT as guideline-based therapy, the one I showed you before. And they added, it's called ALICE, which is amikacin liposome inhalational suspension. The primary endpoint was at 6 months. They got treated longer, and that hasn't been published yet, but the primary endpoint data was published, and that's what helped lead to FDA approval. And that was looking at how many people had converted their culture to negative by 6 months of therapy. So what you see, percent of patients, those who got ALIS, those who got standard therapy, and from the first month on, you can see the separation is already occurring. That those who got ALIS are starting to convert, but look across, if you just keep doing the same thing, they don't convert. So even by up to 6 months, we know who's going to convert and who's not. And if we add this, you can see about 30% of the people converted, the same as what they found in the phase 2 trial, which was a placebo-controlled trial. So this is what we do. If we have a refractory patient, culture positive, out at 6 months, we add liposomal amikacin now. So what are the side effects of this? They're actually quite frequent. Dysphonia, hoarseness, losing your voice, half the people. First day, I just tell them, you're going to lose your voice. And if you're an opera singer, you're probably not going to put up with that very long. But most people don't care. A little hoarseness, they don't care. If you give them a little break, we're learning, like give them a week off and then start it back a little slower, usually they tolerate it. Cough, and if you inhale anything, it makes people cough, some dyspnea, hemoptysis, but not really different. So the main thing we tell patients is when you start it, you're going to have some hoarseness, you're going to cough. Because it's an aminoglycoside, of course, everyone's very afraid about ototoxicity. Tinnitus was more common. Our experience is it resolves when we stop it. Dizziness, more common. Hearing loss, actually less common for some reason. Serious adverse events, the same between the two, not statistically different, and they had to stop ALIS in about 17%, usually due to those symptoms. So we think it's a useful drug. Let me finish with abscessus. This is a patient of mine from New York, 68-year-old woman, chronic cough and fatigue, showed up with this x-ray. What would you do? This is not NTM anymore. TB. That looks like TB. I mean, so she was started on DOT, 4-drug therapy, as she says, quarantined in her home until she grew abscessus and MAC. She grew both. And she grew both of them multiple times. So we actually put her on treatment for both. That was 5 to 6 drugs, 2 IV drugs. We were able to get rid of her MAC, never came back over 8 years. We never got rid of her abscessus, and she died from progressive abscessus. Deaf. What was her profession? Audiologist. So this is abscessus when it's too late. When it's advanced and cavitary, it's very, very difficult. And we have hundreds of these patients. So what is abscessus? Well, it's hard to say. It was discovered in this person's knee in 1953. It was actually given its name in 1992. A group of scientists did some sequencing in 2006 and said there should be 3 species, the ones I mentioned before. But when they named this one, they had a naming violation. They didn't follow the rules, so the name was removed. And they collapsed these two under the term subspecies Belledii, but they're 2 different species, or subspecies. So there are labs now in the US that continue to report it that way. Totally wrong. And then we, in my group that I work with in Korea, 2013, a sequencing study, we said, no, these aren't species, these are subspecies. Let's go back to the subspecies. That was confirmed by Richard Wallace and others at Tyler. And in 2017, the group that had first named it published another paper saying, no, we should name it this. I don't know what the name is, but we're using the subspecies designation, that abscessus has a subspecies, or is a subspecies, Maciliense and Belledii, but they're all abscessus, they're just subspecies. Why does it matter? Well, it depends on where you live. If you look in the US, Netherlands, France, if you look across there, let me highlight what, the different subspecies, you can see that our patients, unfortunately, have mostly subspecies abscessus. But as you get down into Asia, particularly into Korea, half their patients have Maciliense. And you go, who cares? Well, I'm going to show you. You can cure one and you can't cure the other. But just the subspecies makes a difference. So why is this so tough? Because it's just a resistant organism. If you look at the susceptibility, these are the drugs that we typically do drug susceptibility testing for because they have been shown at some point to have activity. But if we just kind of summarize it, you can see that there's quite a variation. The macrolides, though, just like they are for MAC, are very important here because the wild-type organism will usually be susceptible to the macrolides. So it's very important to know this. And this is where that inducible resistance comes in. So there are two kinds of resistance in abscessus. One is mutational. You know, you get a mutation and it just doesn't work. It just, the MICs climb very high. And we can detect that very easily in the lab by just looking at the culture results after a standard 3 to 5 days of incubation. We can sequence, look for the gene, and we even have line probe assays that will find the gene. So it's very easy to find that. What's harder to deal with is the inducible resistance. So what happens here is that the organism has what's called this ERM gene. In this case, it's ERM41. This is very important, and unfortunately, it's present in almost all abscessus. It modifies the binding site of the macrolide so they don't work in the presence of it. So the way you figure this out is instead of reading at 3 to 5 days, you have to hold the culture for 14 days. So what's going to happen is it'll be susceptible here, but now it's being incubated in the agar with the drug macrolide. It induces resistance, and now at 14 days it'll be resistant. But we can use molecular-based methods, as we do, to tell you this. I can tell you in 24 hours if you have inducible resistance. So this is how this works out. So you have clarithromycin susceptibility results. So if you look at the first time point, 3 to 5 days, and then again 14 days, and it's susceptible, that means the ERM gene is not working because the macrolide's working. You can use the macrolide. It's going to be effective, and I'll show you in a moment how effective. But if it's like this, if it's susceptible here, but later is resistant, then the ERM gene is working. That means just sitting in the agar with that macrolide turned on the gene, and it doesn't work anymore. So the macrolide quits working. That means usually abscessus and Belledii. In the other circumstance, it's usually Myceliense. In this case, if you use it, don't count on it because it's probably not working. The easiest, I think, to understand is when there's resistance at both time points. That means there's a point mutation and it just doesn't work. I mean, it's not going to work. The MIC is very high at this point. So this is complicated for labs and for clinicians. So this is kind of the same approach we had for MAC. I want to know the first thing, does it have macrolide resistance? Whether it's inducible or not. If it does have macrolide resistance, then I need to find 2 or more drugs. Usually we add amikacin. We give this for 2+ months. I have a patient who got 13 years of IV. And then we will go to what's kind of more of a holding regimen, not so much a curative regimen. If they're lucky and they have Myceliense, or about 15% of some abscessus, that ERM gene is not working, macrolide works. We use it. Now I don't have to find as many drugs, but the overall approach is pretty similar. These are the drugs that we work with. So you can see that one of the problems here is we don't have a lot of oral drugs. So we use IV drugs like beta-lactams, tigecycline, now eravacycline, linezolid, tedizolid, a lot of clofazimine, and some of the newer agents and some things that are now at really research levels. So if you do that, this is what you would expect. And this is why you have to know this from your lab. So small studies who really sequenced early on and could distinguish abscessus from Myceliense. And the bolded here are what I think are the key points. So if you look at sputum culture conversion, 88% culture conversion, almost 90% if you had Myceliense. So you need to know this. Your patient, you got to tell them what their prognosis is. You've got to build the regimen. It's only 25% if they have abscessus. It's all, and across studies, different countries, different populations, it's the same. So having Myceliense means there's not a non-functional ERM gene, the macrolides work, and it seems like that's all it takes to up the cure rate to almost 90%. Very, very important. We just did a systematic review, 14 studies, and this was individual patients. So we contacted people who had published, we got the primary data, and we were able to analyze it with Dr. Kwok in Shin from Korea, overall treatment success was about 45%. But again, it differed significantly depending on the organism. Now here it was 56. They used very strict criteria for success. If you looked at culture conversion, it's up around 90%. And just like with macro recurrence occurs, this again was the group in Korea. Here's cumulative recurrence rate with NTM lung disease or abscessus. So now we've cured those small number of patients, and we're looking to see recurrence. So this line is showing you that they are getting reinfected with different species. They're coming in with MAC now. The bottom line is showing that some of them are coming back, but less with recurrence of M. abscessus. And in all of those, they had a different genotype pattern. So recurrence is also high. It's an environmental pathogen. So the final point here is if you can't cure them with antimicrobials, you have to go back a little bit and think about surgery. We do VATS surgery, video-assisted thoracoscopic surgery, about 80 to 100 patients a year. And I just want to remind you of the patient that we saw at the beginning who had the big cavity and the bronchiectasis, who had resistant disease. This is her scan after she underwent a right middle lobe, right lower lobe, and superior segment and lingular resection. This was about 9 years ago. She lives here in California, and she has never had MAC again. Everybody told her, just get over it, because we can't do anything about it. And you can do some pretty amazing things with the right surgeon and the right approach.
How many surgeries did you say a year?
80 to 100 patients. And this is one of our, Dr. Mitchell, who is the surgeon. 134 patients, VAT resection, no more, I mean, today, 15 years later, zero operative mortality. Conversion to thoracotomy is now down to about 2%. Post-op complications, 7%. Others have published 25 or 50% complications. And the mean length of stay is a little over 3 days. So people ask us, why do we do surgery? Because we have good results with it in the right patients. So we're running a little behind, so I am going to stop with that and let you read that. But I want to review that this is an emerging problem. It is more prevalent than TB by far in the United States and also Canada, some other countries, Japan. Japan actually has one of the highest rates in the world, higher even than Hawaii. We do need to find out why that is. I mean, why is this happening? We have suboptimal treatment for many of these species, but some of the species we can cure. So it's very important that you have accurate assessment from your laboratory, and particularly when it comes to abscessus, where knowing whether or not there's inducible resistance means a huge difference to your patient's outcome. And then surgical resection. Think about it. There are patients that you need to think that this could work, just like we do with MDR and XDR TB. So I will thank you, and I hope we have some questions.
Resection is usually done after antibiotic treatment?
Yes. Yes, so the question is a surgical resection done after antibiotic treatment? And the answer is 100% yes. If you operate on these patients before you knock the bacterial load down, we see more complications. Complication rate's higher. We see spread to the soft tissues. The wounds get infected. So we try to treat for a minimum of 6 to 8 weeks before. We start everyone on IV amikacin during that time point, unless they have hearing loss and then maybe inhaled amikacin, along with the other 3 drugs, and then we will operate. During that time, the reason we give amikacin is a randomized placebo-controlled study that used streptomycin, a study in Japan, that showed streptomycin had faster bactericidal killing. So we know that if we give amikacin, which is more active than streptomycin, that we're knocking the bacterial load down as low as we can get it before they have surgery. Yes?
You had mentioned the high risk of new infection or recurrence. So in populations that have chronic lung disease, COPD, CF, if you could just describe your surveillance plan and kind of when do you repeat sputum?
Yeah. So because we're so worried about recurrence and reinfection, we do sputum every 3 to 6 months in that first year after they stop, and then usually about every 6 months thereafter, and we tell them we never stop looking. We almost never have to do bronchoscopy. We use sputum induction and have very, very high yields with that. We image periodically. The first year, usually it's 6 months and 12, and then we try to stretch it out if they're stable, and maybe just do chest x-rays. Yes?
I just want to recognize that folks who do NTM work use a lot more clofazimine and have a lot more experience with bedaquiline than people in the TV world. We're all nervous. So I do want to ask Chuck, individually, what do you see with all those patients on clofazimine? How do you coach them? Do you feel like it's pretty easy? And then individually with bedaquiline. And then you have a lot of people on a combination. How
Yeah.
often are you seeing?
Yeah, so I said around 300. Actually, I think it's more than 300 on clofazimine, both MAC and abscessus and other species. CME is something we see in California now, and that's a very resistant organism, so we use clofazimine in all of those patients. We also use bedaquiline in all those patients. If I give someone bedaquiline, they always get clofazimine.
So you're combining
Yeah.
the two. How often
Yeah.
are you seeing QT prolongation?
0. I mean, we haven't had to stop it. We see mild amounts of QTC prolongation, and I'll tell you, those same patients are often on a quinolone or a macrolide.
But so the thing is, so you're feeling pretty good about it, but you are following EKG.
We do follow EKGs. We do EKGs at 1 month. Well, on bedaquiline, we do them monthly. For clofazimine, we do them at 1 month and then every 6 months. And I'll tell you, we only do this because it's required pretty much by FDA and our IRB. We were using clofazimine for 30, 40 years before that and never looked at an EKG, and none of us ever saw a problem.
But solo, without other QT prolonging drugs.
No, they always were.
Always with.
They're always on something.
Yeah, because I think that's Gisela Schechter was saying, oh my goodness, we used to use clofazimine all the time.
Yeah.
Tell them they might turn
Yeah.
orange. But otherwise, it's okay. And leprosy docs will tell you,
Yeah.
this is really pretty easy drug to use. But
Yeah.
for us, it's new again. It's harder for us to get unless you have an NTM program
Yeah.
that's getting it right there in your site. But
Yeah, we just, all they have to do is sign consent, and we have it in 10 to 14 days. So, and it's free. So it's funny because around the country I hear all these docs, we get like 1,000 consults a year, and all patient refused clofazimine. I go, you need to let me talk to them.
what do you say to that? I think that's the practical. What do you say to us about clofazimine? We're all going to be doing that.
Yeah, so there's a difference between TB patients in this regard and our NTM. Who are my NTM patients mostly? Fair-skinned, Caucasian women. They don't get very dark. They look good. I mean, they come in. I had an 80-something-year-old lady. I had reduced her dose from 100 to 50 because of dry skin. That's actually more problematic because older people, they get dry skin, and clofazimine will dry your skin, so they itch. And so we'll reduce the dose. She walked into my room like 6 months later, shook my hand and goes, can I go back to 100 milligrams? And I go, why? And she goes, well, I've lost my tan. Because they actually look very healthy. We call it a glow. They don't really turn orange or anything. It's just, it's the color of the medicine, and they get a kind of a brown. Now, if I gave them 500-600 a day, like they used to be done a few decades ago, oh, you got all these weird colors. That's what you see on the internet. You also see, where were these given? Most of this that's been reported is from India and Bangladesh. Darker skin there is stigmatizing. But in Minnesota and Wisconsin, it just means you went on vacation. And all winter. Now, I mean, honestly, I'm making light of it, but it is not an issue in the patients that we're treating primarily with this. Now, my Korean patients get very dark. And they do. And we'll go to 50. We'll go from 100 to 50 if either we or the patient, we think their skin is getting a little too dry or too dark. It's not permanent.
You said that your N is
300 plus.
And is the age of your patients? It sounds like some of them are pretty old.
Yeah, our average age, this is where they also differ from TB. I mean, their average age is probably 65 to 70.
Yeah, that's what our average is.
Yeah.
But so do you get an echo prior or anything like that, or do you just go for?
We do EKG, but not echo, but we get a baseline EKG, and then in the frequency that I mentioned, if we see an abnormality, like they already have a prolonged QT, we will monitor more quickly. We published our results with this, and we're writing a letter right now, a research letter with 300 plus that had EKGs at least at baseline in 6 or more months. Just to make this point, I think people really are over concerned about what clofazimine does. And almost all of those patients had at least 1 or 2 other QTC prolonging drugs.
And how long do you let that take?
500. And by the way, some of these patients have been on clofazimine, like these abscessus patients that I'm just trying to slow things down and I'm not curing. They've been on it for 3, 4, 5 years. I have 2 patients I saw this week who've been on it for about 5 years. So I think, and bedaquiline. Our experience with bedaquiline has been really well tolerated. I think we've had to stop it maybe in 2 people because of adverse reactions. One was hives, if I'm recalling, my patient, another. And one was LFT. But they've really done well on it. I saw, yes.
Recently, use of tobramycin inhalation, because we have some patients that have been on
Toby. On Toby? So tobramycin does not have much activity against the organisms that I reviewed today, but it is the best aminoglycoside for Mycobacterium cheiloni. It has the lowest MIC, so we use it there, but we don't really use it in other NTM. But for that one, it's our first choice.
I'm going to say try to stay with us
Yes.
through the day. Please feel free to
Take your break.
I'm going to off. Thank you very much, Jeff.